So, we are going to start. Ladies and gentlemen, it is a great pleasure and an honor to be here with you following our scientific session of the ECTRIMS Congress. I'm Bruno Stankov. I'm a neurologist in Paris, France, and also a researcher. And I'm going to act as the president of ECTRIMS during the coming years. I'm really happy and proud to be here with you. It is our third time that we organize this patient community day, just following the ECTRIMS event. This is a growing and moving event. We thank very warmly all of you for being here. The numbers are increasing. You are quite a lot today. And for just a brief history, we started to organize this 3 years ago by realizing that we're doing a lot of science, a lot of medicine here, but that we deeply needed to provide on a short time frame a good and fair and simple information to the people who are the most concerned about what we are discussing about you, the patient with diseases. So we started the first event. It was a quite small event because people were not knowing too much. And we realized that this is increasing and increasing during the years. And for your information, you are partly here in the room, but this is also a connected event with a live broadcasting of it. So yeah, a lot of people, more than 2,000 that are registered for assisting to this community event. This year, we have changed a little bit the format. Last year, we made quite scientific presentations summarizing what has been shown during the Congress. It was a little bit complex, and this year, we'll see, you will be presented to our panel just after, but this will be more a kind of debate illustrating what has been said. And we think that it will be more simple, more fair, and more informative for you. Do not hesitate after the event or even during to ask questions or to provide feedback. This is an evolving thing, and we will adapt according to what you accept. I want to warmly thank the Danish MS Society for being here, for supporting all of us here, and all the other supporting partners that you can see over there near the wall. And I will just briefly now close this short introduction and give the word to Finn Selberg, who has been the local chair of this session of ECTRIMS, and who is also the chair of the Neurology and MS and Inflammatory Disorder Unit. Thank you very much, Finn, and congratulations for having put together these events.
Thank you, Bruno, for this kind introduction. So I'm Finn Selberg. I'm a neurologist from Copenhagen, and I've had the honor and the privilege to be the local chair of the 3 days of research meeting that we've just concluded 1 hour ago. My task here is quite simple. I have to say velkommen til jer alle sammen in Danish. Welcome to all of you. It's really a pleasure to be allowed to say a few words here. Bruno mentioned that it's the third time we have the ECTRIMS Patient Community Day. And it's the third time that we have an ECTRIMS meeting here in Copenhagen. The first was in 1996. And indeed, there is a long history of MS research being conducted here in Copenhagen. In the 1950s, the Danish MS Society was founded the Danish MS registry was founded. Brilliant researchers started investigating why people get MS, and the first genetic factor to be associated definitely with MS was in fact also discovered here in Copenhagen. The first clinical study of interference ever in the world were conducted here in Copenhagen. So there's really a legacy for interesting and highly innovative research to be presented and discussed here in Copenhagen. So it's really on that note that today we'll have the opportunity for people living with MS to discuss what has been investigated, what has been discovered, and what will be the consequences of these discoveries for people living with MS and their families. So with these introductory words, I would like to welcome you all here once again. I hope we will have some really brilliant and informative discussions. And with that, I would like to hand over to our moderator and host for this afternoon, please, Brett Drummond.
Thanks, everyone. So welcome to our Patient Community Day event for 2024. As Finn said, my name is Brett Drummond. If the accent hasn't given away, I'm joining you from very far away from Melbourne, Australia. 12 years ago, I left MS research to take up a career in science communication with a goal of bridging the gap between people living with MS and MS research. Fast forward to where we are today, and this is amazing. I wish, and I encourage you all to take a second to look around the room at the moment, to see all of these faces joining us here in Copenhagen to participate in this event is amazing. You should all be congratulated because these events are happening because of your engagement, your dedication, and your perseverance to push the research community to make sure that we communicate our findings to you, the people who are directly impacted by it. We are really excited about this event today. As Bruno said, we have a completely new format for this year, which we hope you will enjoy, but please do give us feedback as we go through. We want to continue to make this event better and better for you, the people who we are doing it for. So to give you an overview of how today is going to run, we have picked in session 1 6 key topics from this conference that we know are topics of interest to people living with MS and people living with other neurological conditions. Each of these topics we will be covering a little bit briefly due to time constraints. So we will be starting with a brief introduction to each and then throwing across to the panel who will engage in a lively discussion about the topic and what we've heard on that topic from the conference. At the end of each topic, we will be taking a question submitted online and posing that to our panel before we move on to the next topic. We will then have time at the end of each session to take questions from our wonderful audience who are here with us today. To let you know, we had around 400 people registered to join us in person, which is amazing. And looking at the room today, I think a lot of you have come along. We also have an amazingly large audience of close to 2,000 people who are joining us online at the moment. So welcome to all of those people as well. So without further ado, let's get into our first of our hot topics, which is going to be... before I do that, let me jump back. Let me introduce to you our panel of people who we have here today. And I want to say to start with that all of these individuals accepted this so excitingly, and these were all of our people who we first chose. And when you look at the lineup of amazing individuals who have done this, I think this really emphasizes the commitment that ECTRIMS and all of the MS community have to this event. So starting from my left here, we have Tim Kutzi, who's CEO of the National MS Society. Next to me here is Myelin Kaplan-Kruger, a patent attorney, and wonderfully a person living with MS joining us on the panel as well. Melinda Magyari, director of the Danish MS Registry. Have Bruno Stankoff, who you've already met from Sorbonne University. Martin Torre, current president of ECTRIMS, joining us from SEMCAT in Spain. And last but definitely not least, Mitzi Joy Williams, neurologist from the Joy Life Wellness MS Center in the USA. So an amazing panel of people to share their insights with you today. So our first topic, even though the title hasn't come up on our slide here, I can tell you that I know which one this is remyelination. So just to put it into context before we throw across to our panel here, while we have a number of existing treatments that can now stop new damage from occurring or slow new damage from occurring, none of our current therapies are able to repair that damage once it exists. This is why remyelination or myelin repair is so important. It is really seen as the next major advancement in the treatment of MS, because we have a hope that with an effective remyelination therapy, we can start to restore function. So with that, I'd like to throw to Tim to give your thoughts on remyelination in general and what we've heard about it at ECTRIMS 2024.
Well, I think, first of all, it's great to be with all of you. You know, as Brett said, remyelination and myelin repair is truly the next frontier. And one of the things that has excited me about the conference is that it's not something that's so far off. We have known that the body can repair itself and that the brain can repair itself. I wasn't here 20 years ago for the ECTRIMS, but back then, I think myelin repair was seen as so far off as almost impossible, almost unimaginable. And certainly that's how it was described when I started in the field as a researcher. But now we have treatments in clinical trial today that are being tested and being evaluated. The important aspect that I think we need to take away from the conference is beyond the fact that we have treatments and imagining how to use them, it also highlights the importance of being able to have treatments that stop the damage from happening. Because in order to repair a damaged nerve cell, one must have nerve cells still there for myelin to be repair to happen. And so it emphasizes the need to have both treatments that stop the disease, identify early intervention, but also some of the other advances around protecting the brain when it is experiencing the damage associated with MS. And that's, you know, that creates a supportive environment in which myelin repair can happen. And at the conference, we've had a number of conversations about early stages, early molecules that are being tested and evaluated, and it has great possibility for people today. We have had some trials that have not been successful, but we've also learned when to use the treatment, when to begin evaluating it, and then most importantly, how to use it in combination with other treatments.
Bruno, I know this is a topic that you're keen to discuss.
Yes, it may appear as a, let's say, complex field, and it has been a matter of decades of research, which has been mostly a biological research. But we learned a lot about the mechanisms that may underlie how the brain can repair itself. And we are now more clear about this. And what has been shown here is some advances about who are the actors, the cells that will play a key role in the repair process, and that we may target with drugs in trials. Because at the beginning, we were thinking that remyelination, it's only the matter of the remyelinating cell, but it's also the matter of the environment. And Tim mentioned very well that you need a healthy neuron to be repaired, but you need also a welcoming environment, as usual. And so this welcoming environment depends on other cells such as astrocytes, macrophages, and so on. It's a little bit technical, but what has been presented during the remyelination session here was very accurate mechanisms that could be targeted for future trials. The second casing is how we are going to conduct this trial. It's not a so simple question. It's not the same than preventing relapse. And so we have now made progresses in terms of the outcomes that we can use that may capture the neuroprotective effect of a drug or the remyelinating effect of a drug. I would mention a very interesting work performed by a young student that developed an artificial intelligence tool that is applying now to everybody, maybe in real life, to capture the remyelination process. And by having enhanced such tool, we'll advance and accelerate the development of this research for remyelination. And so now the point where we are is also that we have many potential drugs that could be applied further in originally designed trials. And some are already ongoing. We heard a few years ago that clemastine, for instance, were able to promote a little bit remyelination in CNS. And then there have been a second drug, bexarotene, and there are now plenty of potential drugs that could be applied. And we have to think about how they could be applied. So it will be the time of enrollment of subjects in those, at this stage, still small trials. It's not the huge trials that you can see in phase 3, but they are very promising. And we hope that this may accelerate the application of those drugs and those concepts to the real life.
Fantastic. And so we've had a question submitted online that I want to throw to the panel for a quick answer, because it's going to be not an easy question, but I think one that is important that we discuss. Because with all of these, we really want to put this into a context of what does it mean for you, the audience. So to summarize what we're saying, we've made a lot of advancements in terms of our understanding of what controls these repair processes. We're going through the process of now starting clinical trials in this area. So the question that we've received from a number of people is, what do we think is the time frame, the realistic time frame before we might see an effective remyelination therapy approved? A very difficult question to start with, that no one is going to want to answer. It's
a horrible question. It's not, because we cannot engage on this field. It's very difficult. It depends on how powerful will be the first or the first set of drugs we will test. We are talking about years, not about decades. This is what we can say. We are trying to do our best to accelerate. And we are doing international effort to accelerate. For instance, ECTRIMS, together with partners such as NMSD and so on, we have organized meetings this year to discuss about how we can accelerate this research, how we can conduct trials. And so this kind of international collaborative effort is the best that we can do, you know, to push forward those trials and to say we can probably advance this field in years, probably not in decades.
I'd like to add that in research there is always also the fact that the most difficult things are always the first ones, no? And we have seen this with immunomodulation, no? When I started working with this disease, there were no treatments, and it was like impossible to think about treatments. Once we understood that there was an inflammatory process and that we started with the first, let's say, anti-inflammatory drugs, then there was like a cascade, no? And I think this is where we are with the remyelination process. We are at the first steps, and hopefully we will see also this cascade of new things coming once we have understood better what is happening. Because this is a very translational disease. And if we don't understand what is happening, it is very difficult to try to reverse the process. So it's been a long time because it's a difficult process. And the good thing is that we understand now better what is happening. And I'm convinced this is going to have like this spread of more concrete things.
Tim, did you want to finish off on this?
So to build on what Mara and Bruno have outlined, I think the aspects one can also keep in mind is that what's happening today, convening activities like ECTRIMS has created, are actually accelerating the process. So clinical trials are typically 1, 2, 3 years in length, and that is how a typical trial will take place. But the opportunity of collaboration, sharing of information about what has worked, what hasn't worked, happens so much more quickly today as a result of the scientists gathering together and knowledge about outcome measures that work or don't work. Instead of taking years, sometimes decades, to be incorporated into trials, are now more months and maybe a year or so. And so that collaboration is something to be hopeful for. It is hard to accelerate the scientific process, but one of the things we can do as organizations is accelerate collaboration and imagination, and that's what we saw at this conference, and what gives me hope that myelin repair now, as Bruno said, not in terms of decades, but in terms of years, and maybe hopefully soon really accelerating that first phase 3 clinical trial that will be presented at the late-breaking session of a future ECTRIMS.
Perfect way to finish off. As you can see, we have a lot that we can say on all of these topics, but in the interest of time, we do need to move on. So the next topic that we're going to be talking about here is emerging therapies with a particular focus on progressive MS. So while we've made significant advances in the treatment of MS, we know there is still more work that needs to be done. We know that some people living with MS just don't respond to some of the existing treatments and continue to experience disease progression. We also know, unfortunately, there are still very few approved treatments for progressive MS, and so this is a really large area of unmet need and one that we are focusing on incredibly heavily at conferences. And so for this one, Ma, I thought we might start with you for an update on where we stand with this topic.
Yes, thank you, Red. So I think we have learned several things when we talk about progressive MS. Is that the best thing is to prevent it, no? And this is where early diagnosis and early treatment play a crucial role, because we have learned that with this, at least we can delay by decades progression. So this is the first thing. The second thing is that we can increase our reserve, our functional reserve, which means that we will also delay progression. And we have learned that we can increase this functional reserve by exercising, with diet, with cognitive, and using our cognition, etc. All this is increasing our reserve. Also socializing, very important, because it also increases our reserve. What happens once we are already in this phase? We know that if we take out inflammation, progression will also be more slow. So again, in this progressive phase, taking out inflammation is also crucial. And finally, for those people that have progression without inflammation, and this is where there is more debate in which are the drugs that can help or cannot help, we just heard this morning about a positive phase 3 result with one drug that is small. So when I say small, that means that it can cross the CNS and go into the central nervous system. And although it's been just a flash, what we have seen, the first primary outcome, who was delay in progression, was met. Okay, so compared to placebo, this drug seems to decrease by 30% the progression of disability. Of course, this is a phase 3 trial, which is already a good number of patients incorporated. There are things that we don't understand in these first results, because, for example, this was not translated into, for example, a decrease in the global atrophy of the brain, which is something that we are usually coupling one thing with the other. And the other thing is that this drug doesn't seem to have an anti-inflammatory effect. Okay, so it seems to have an effect in progression, but not directly in the acute inflammatory process. So there are these two components. We need to further see the results, because of course this has been like seeing for 6 minutes the slides, and there's a lot to read, and we don't have the paper, etc. But this is, I think, a promising achievement. This is what we were aiming, to look for drugs that could have a role in this progression without relapses, because this is where we are have more difficulties in changing the natural history.
And if I could just add to that, I mean, Mar, you definitely eloquently explained it. I think the key, you know, when I think about patient day and I think about these types of activities, one thing that I try to stress in the exam room to all of my patients whenever I give a talk is that there are things that you can do to prevent progression, right? Oftentimes when people are diagnosed with a neuroimmune condition, they may feel very helpless. Oftentimes the relapses come unannounced, but we're learning more about how these healthy behaviors, and I know we'll talk a little bit about lifestyle modification later, but how these healthy behaviors not just help you to look a certain way and fit in a certain outfit, but actually there's data showing that we can slow brain atrophy if you're engaging in these things like exercising on a regular basis, eating a well-balanced diet, decreasing stress, those types of activities. And so I think, you know, if there's anything, you know, that we can take home from this is that, yes, there's promising research, there are certainly tools and medications that have some promising results, but also that there are things that you can do aside from going to the doctor every, you know, for your visits and following up and taking your medication, that can literally impact the health of your brain and increase your reserve to protect against progression.
Perfect. And our question that was submitted around this, Mar, you've done a perfect job of answering before I've even asked it, which makes things easy in the interest of time, around PIRA, progression independent of relapse activity, and whether or not there are any studies or trials that are addressing this, which we've seen obviously in the studies that you've presented today. So we will move on to our next topic, which is, getting it here, risk factors. So we know that MS, as a lot of people in the room will know, there are many genetic and environmental risk factors that can increase the risk of developing MS. And it's a combination of these two that seem to be involved. Over the past couple of years, you've probably all heard about the Epstein-Barr virus story, or EBV, which has really shown itself to be the leading risk factor for MS. But we continue to be interested in understanding these risk factors because it can help us with developing strategies for preventing MS, and also tell us more about what's going on in the disease process to hopefully get some more targeted treatments. So on this topic, Bruno, I thought we might start with you to give us a bit of an introduction into where things stand in terms of our understanding of these.
This is, of course, a key topic. We realize that sooner we understand the thing in the process of the disease, better will be our intervention. And this is just what has been said before. We realize that we should target progression as the disease starts, and if we prevent it, it will be delayed at least. And now we are looking at the risk factors. So the global field that has opened is that we may think about preventing the disease. It's not achieved. But this is one of the goals that we can foresee now in the next future. So one of the first steps about this, and this has been deeply discussed during our Congress, was to describe the first stages of the disease, to really capture what happens at the first event that may even precede the disease. And the second point is to understand what could be the mechanisms that expose to a very high risk or a higher risk of multiple sclerosis. And we have understood a lot during the past year, and we have understood a lot more during this Congress here. About, on one side, the genetic of patient. It's not a genetic disease, but the genetic environment of each individual may provide a certain risk to have this disease because it, let's say, pushes the immune system to be a certain conformation that it is more prone to attack the central nervous system and the mind. And we have made key progresses in understanding these genetic factors. The second factor, which are called more environmental, are driven mostly by probable infection. And work on EBV, and we are just starting to really understand how EBV interacts with our organism to favor. It's not the causative agent like EBV equal MS, of course, no. But we know that it is a risk factor, and by studying once how the genome of the EBV could influence the risk, we have understood that there are different strains of this virus, and each strain provides a different risk level. And some strains of virus might provide a very high risk, and they will interact with the genetic risk. So we are now at the stage where we can put, let's say, a relative risk factor from 1 to 250 if we make this kind of research about the genome of both the individual and the virus. So we are really capturing very important risk factor. And this opens the possibility to prevent. Other risk factors are being characterized, and I think my colleague will detail a little bit them, but environment, intoxication by smoking, whatever, I don't know, probably you can rebound. They are not the only risk of the disease, but these are really an important one, and we are going to understand better and better. And many communication have shown very promising results about this.
And Melinda, I wonder whether I can ask you on this, as the head of the Danish MS registry, how important are registries in terms of our understanding of this and collecting data across people living with MS?
Good quality registries are crucial because you have information like the Danish MS registry. We have followed the Danish population over 70 years. Therefore, we can go back and ask, what is the difference between the people who developed MS and those who did not, and just connecting to the risk factors. In that way, we could link it to very old school records and look at that overweight in puberty increase the risk. And this would not have been possible without having the registry, because registry is data is information, and we can do good science having good information.
It's a really valuable way that I guess our audience... Oh, Maya, yes,
I would
please.
like to add that the Danish registry is the envy of all the international community.
So for people in the audience that may have contributed to this registry, everyone is jealous of you. So I guess to ask our question on this, coming back to Bruno, you touched upon EBV. This is going to be another difficult question, but there's a lot of interest from our online audience around an EBV vaccine and its potential to prevent MS in the future. Does anyone want to share any thoughts they have on that?
Okay. Thank you very much for this question. So this is, of course, an opportunity, of course. And clearly, as probably you cannot have MS without having EBV around, probably, in theory, avoiding EBV would have a strong impact on the disease onset. So we need data, and there are coming trials, and which is a very good news, because those kind of vaccinations are being developed, and the first trials are starting. It's not an easy thing, because EBV infection may occur early during life in children. So have we to focus on very early phase of the life? Have we to vaccine again people who have been already infected? There are many, many questions about it. But this is an opening and very large field of research. And here again, it's like remyelination. It's not decades, probably it's years to have those information. And this will take place.
And I think, Brett, one aspect I'd add to Bruno's point about why it's going so fast is that one of the things that COVID developed was the way to do vaccines in a new way. And so one of the benefits, actually, of the incredible technology is now we can apply that technology to diseases such as EBV and other places. And so that serves as an accelerator that can really be imaginative, and it allows us to test these vaccines in a way that we could not have imagined even 4 or 5 years ago. And it really gives us some hope that we could have solutions very quickly.
And I would like to add that we are not the only ones that are interested in the EBV vaccine, because EBV is also related to many other conditions, hematological conditions, and so all the medical community, I think, is absolutely committed with these results, and we are all very, very well paying attention.
Perfect. So, moving from that onto our next topic around symptom management, and just as a quick note to our online audience that we should have mentioned at the start, this is being recorded and can be accessed after the event as well. So in terms of symptom management, again, while we have advances in treatment, we know that people living with MS are still affected by symptoms on a daily basis. Symptoms such as fatigue, cognitive impairment, incontinence, mental health issues, these can have a large impact on daily activities. So while we continue to try and progress better treatments, we know that we also need to place a focus on understanding these and finding better ways to manage these symptoms to improve quality of life for people living with MS. Because of that, symptom management and understanding these symptoms is a major topic at the conference. And I wondered, with this topic, whether Mitzi, you might lead us off on this.
Absolutely. So there were some great sessions. I wasn't able to attend all of them, but on symptoms such as sleep, which is a huge issue for many of my MS patients. I think one of the difficulties is that oftentimes symptoms can be multifactorial. So there are many things that can cause symptoms, and then sometimes the treatment for one symptom can make another symptom worse, right? So if we treat your spasticity or we treat nerve pain, oftentimes those medications can cause fatigue, or if we treat people for fatigue, sometimes that will cause difficulty with sleep. So it really is very important to make sure that people are connected with their neurologist, as well as with their GP and other specialists, to try to make sure that we're finding the best balance for treating these symptoms. I think something that's also been very interesting is we talked a lot about cognition during the course of this conference, and so cognition, recognizing that it is something that can be affected very early in disease, and trying to find good measures to see how cognition may or may not be worsening over the course of disease, and also using cognition and cognitive changes as a measure of progression. So I think that's very interesting, and I think that we need to make sure that we have tools that people can use, that our neurologists can use in the clinic on a regular basis to monitor that, and also that patients are aware that if their cognition is changing, this could be a sign of progression to relate to their neurologists and other physicians.
Yeah, I would like to add that it's also efforts that we could include some of these symptoms in registries that to give a better performance of a more complex measurement of progression and disease worsening, which also could be used to measure treatment effectiveness. So that could be a future.
Huh?
I would like to add that we are having more and more evidence about the efficacy of exercising, of rehabilitation, of moving, of socializing, all these factors that were a bit forgotten, especially by neurologists. I think they are gaining more and more. We do have data now that corroborate that with more exercise we can decrease fatigue, with more exercise we can decrease depression, with more exercise we can decrease pain. Socializing also is key. So I think all this has also been presented, how and if you combine exercise with socializing, with diet, there's also this increasing effect, no? So more and more we are aware of not only the medication, but also the power of all these interventions.
If I may add just one word, is that in the daily life, big part, let's say, of the time between the patient and neurologist is taken by the discussion around immune modulating treatment. However, we should not forget to discuss about those symptomatic problems. And you mentioned the fatigue and the sleep disorders, for instance. They are usually underexplored. Do not hesitate to discuss this with the clinicians, because there are some solutions to improve sleep, to treat sleepiness, to explore why the sleep is not correct, why you have too much fatigue and so on. So this should be a big part also of the consultation between a patient and his doctor or her doctor.
And would you say that one of the shifts in terms of how we've thought about this is that we don't want to wait until it's too late? That with things like rehabilitation, previously it may have been, once we started to lose mobility, that we would try and restore function. Whereas now it's about how can we preserve it the longest. Mitzi, I don't know if you ties in with what you were saying at the start. Are we now trying to get this early before we lose function?
Yeah, so I think about it, I've had conversations with Gavin Giovannoni about this, but this idea of prehabilitation, right? If we think about someone who is preparing for surgery, they are, sent to do exercises and strengthen themselves as much as possible so that after that intervention or that surgery, they have a better ability to bounce back from that injury. So, thinking about MS in terms of how can we get people in the best shape possible and start these healthy behaviors, et cetera, from the beginning instead of waiting for something to happen and then being reactive with lifestyle modifications, et cetera.
Perfect. We will continue to move on to our next topic, which was perfectly transitioned to by Mitzi, which is lifestyle modifications. And so in terms of lifestyle modifications, we know that one of the biggest feedback that has come through to researchers and to healthcare professionals around MS is a desire for people living with MS to be able to take control of their disease. And we know that this is one way that they can do that. Diet and exercise are key features in this plan, and they've proven to be effective as part of an overall MS management plan. Where the research world really is at the moment is discussing what are the best ways to implement these factors. And I think on this topic, Myelin, I might start with you because I think this is a really interesting topic to hear your thoughts on in terms of how important it is we're discussing those things at a conference like ECTRIMS.
Thank you very much. Very important indeed. I'm sure all of you out there will agree that this is a topic we really want to learn more about. We really want to, while we appreciate all of the nice medical treatments we get, disease-modifying treatments, symptom management, and so on, we really want to also contribute ourselves to give our brains, our immune system, the really best conditions for not making us sick and even perhaps help curing us from the symptoms we already have. So I think I have been attending this conference, and I think the really good news here when it comes to lifestyle management is that there is an increasing awareness in the medical world about this, which is really, really good because we are so desperate to get guidance on how we are supposed to live our lives and hopefully scientifically based guidance. There have been 4 sessions that I have been attending which somehow relate to lifestyle management. There was a very interesting one this morning on physical and cognitive rehabilitation. And we have really solid evidence today that exercising helps. It improves physical capabilities. There is also indications that it can improve cognitive function. It's a little bit more shaky, but there are indications at least, and good hope that this is so. There was also something on cognitive rehabilitation, which is also really important. Then there has been a really interesting session today also on diet. How can we, again, help our body the best way possible? 60% of, maybe it was 40%. I think it was 40%, sorry. of MS patients have tried to change their diet, and many of us feel that it helps, but again, we would like more solid evidence. And the not so encouraging news in the speech today was that there's still no solid proof of recommending one MS diet over another. We simply don't know. So the best recommendation was to eat a full and healthy diet, manage your weight, don't get underweight, and yeah, so that was the main message. And again, exercising is better than supplements. Very important message also. There was a presentation on fish and fish oil. While fish has been associated with good development for MS for many years, a study was presented that the polyunsaturated fish oils themselves did not, no effect could be shown. But still, again, there are much of other good things in fish, so many good reasons to eat fish. There have also been sessions on sleep, how important it is to sleep, and this can be very difficult to change. But the main message when it comes to my lifestyle here was do your best. Sleep is really important. If you don't sleep, it increases fatigue, sleepiness during the day, and yeah, everything should really be done. And the last session, which I would think relates to lifestyle management, was one on microbiota, your gut microorganisms, where there's also so much more knowledge than just a few years back. It has now been shown that MS patients, our microbiome is different from healthy people. We have an overrepresentation of pro-inflammatory microorganisms and an underrepresentation of good immunoregulatory microorganisms. Again, perhaps not so easy to change with your lifestyle, but there are some things to do. Probiotics, prebiotics, fiber, vegetables, and which probiotics to I think Lactobacillus rhamnosus is one of the ones I hear mentioned again and again. So yes, very interesting also when it comes to lifestyle factors. Lots of awareness, and we know more all the time.
Yeah, I'd like to add, I think that this is really exciting. For me, learning about these lifestyle factors, in medical school, I don't know about everyone else in their training, but we maybe spent 2 weeks on nutrition. So it's not as if we got, a lot of education about nutrition. And I'm very excited to see that there are studies focused on this, but also, again, underscoring the importance that I always say there's a part medicine plays and there's a part you play in your own health. And no disease-modifying therapy, no symptomatic management gets rid of the part that you play in improving your own health. And again, this really emphasizes and underscores that there are things that people and individuals living with these conditions can do to help themselves. And I think it's important also to recognize that it's going to look a little bit different for each person. I've had people who've been successful on all diets. The one that they can stick with is the one they do the best with. In terms of exercise, it doesn't necessarily have to be you putting on a certain outfit and going to run on the treadmill for an hour. It could be walking a little bit more. So it's really about finding that plan and that routine and that prescription, so to speak, that is best for you. And I think that, being able to emphasize that and focus on that is really important and exciting for those of us in the field helping our patients.
And another thing I forgot to mention was to mind our comorbidities. While there are lots of things which may not directly affect our MS itself, if we can avoid getting diabetes, the high cholesterol, high blood pressure, if we can avoid obesity, and we also really help ourselves. So mind all of these factors also, very important.
Yeah, especially in the aging population, which is crucial. And I would add that we have so many data about the problem of smoking, about the consequences of smoking in terms of increasing progression, decreasing capacity of restoration, So really lots of data contributing to this. The good news is that if you stop smoking, some of these things seems to be reversible. So please stop smoking.
An important message as we move on to the next one. And I think one of the things that just came up in that is that we know that all people living with MS are different. MS is a very global disease. It affects around 3 million people worldwide. And we know from studies that have been done, and Mitzi, I'm going to start with you on this because I know you've been integral to publishing some of these studies, have shown that factors such as sex, race, ethnicity, age, and social determinants do have a big outcome, a big impact on health outcomes in people living with MS. Part of the problem is that currently clinical trial cohorts don't always reflect the diversity that's in the MS population. And so this is something that I think we need to place a really large focus on. And Mitzi, I'd love for you to share your thoughts on this.
Yes, well, you know, I could spend the whole hour talking about this, but I don't have time. I think one of the things that made me very passionate about this type of work is that I live in Atlanta, Georgia, in the South, in the United States, and much of my population of MS patients did not reflect the type of patients that I learned about in my residency training. So the majority of my patients are young Black women. And so when I would go to the literature to try to understand why there are some people who may have worse disease, et cetera, there was no data. And so I think it reflects the fact that the face of MS is changing over time. As we're learning more about MS in different parts of the world, we need to make sure that the treatments, the interventions that we're doing reflect the people that will actually be affected by those interventions, whether it is a person of a different ethnic background, whether it is a person who is over the age of 55, you know, for the purpose of our studies, or a pediatric population, you know. So there's a lot of work that needs to be done to make sure that we diversify our clinical research so that we can make sure when we go to those patients that we have answers or at least some data to tell them that they are reflected in the data with whatever intervention or medication, et cetera, that's been developed.
Yeah, and therefore, again, with registries are very important because then we collect data on an unselected population. And then combining from different countries, we can answer questions on this underrepresented population. And I think this week we just, our paper about the diagnostic challenge in underrepresented population came out. And like the social determinants, we had a poster about the Danish population showing that differences in education and level can influence the treatment delay. So education and perception of information can influence health behavior or health literacy. So,
one of the most amazing sessions that I have attended was this morning, where there were neurologists from the whole world explaining their challenges in making the differential diagnosis in Africa, in Middle East, in Asia, in Russia. So very, very interesting, because you realize how diverse is this differential diagnosis, which in Europe is usually much easier, but they are facing really complicated differential diagnosis, and there's so much that we have to learn.
So on this topic, we received a number of questions from our online audience, particularly around the concept of older age and feeling like once they got to an older age, they were being excluded from trial participation. Anyone have any thoughts around that and whether we should see changes in that space, especially as we see people living with MS living to old ages due to the success of treatments that we have now? Tim?
Go ahead, Melinda. No, me? Okay. So that is a really important issue, and there's some information, for example, that was shared at a conference that ECTRIMS and the National MS Society convened earlier this year, where more than half of the people living with MS in the United States are over the age of 55 out of the 1 million, and we are not. This is a challenge to the community because we have not thought about life with MS in terms of aging. that people would get older with MS. And that has really brought in challenges. We don't understand how the disease-modifying treatments perform in an older person. There's more cases of diagnosis of MS in an older person. And the other challenge is clinical trials. The clinical trials have typically been designed for younger populations, and part of it is not so much regulations, but really when the trials are designed, they want a specific population of patients and don't take into account that older people could also contribute. And so we need to change attitudes around the researchers who design clinical trials, need to change attitudes with the regulatory authorities, also with the companies that conduct clinical trials, to broaden the population, but also recognize that in some instances, asking someone who is over the age of 65 to participate in a trial may not actually be a good thing, because that person may not respond to the drug, and in that case, they've participated in a trial where it hasn't actually had a benefit and wouldn't contribute. And so part of the challenge, the caution of these companies is around, will I get in trouble? Will I potentially injure someone? And we need to have this conversation. That's what we must confront as a community, and importantly, engage the patient community. All too often, the decision is made by individuals who are not talking to patients, and we as a community must confront that so that we actually have all the voices at the table.
Yeah. And I'd like to say that 55 is not old, for the record.
No.
I did not mean that.
No, I know you did.
But I think we have the same problem at all extreme age, because we had the same problem with children with MS, and it has been very long to start trials in this specific subpopulation. And we know that it is fundamental and useful to have this data. So the same problem is for people with growing age, and we have to think again. It was the same for remyelination, for all new approach. We have to think about also new way of having data on this population, combining classical trial, more inclusive for patients with characters such as age, but that might be other characteristics, and combining also well-designed real-life data. They may be very informative, and we're talking about new design to explore the effect of therapeutic strategies in those merged data, sometimes a trial and combined with the registry data that is well done, and you can have a lot of information about these extreme conditions.
Yeah, absolutely, because safety reasons was one of the reasons why clinical trials stopped at 55. There are discussions to increase and in some trials are included patients up to 65. However, we also have to understand the difference of aging with multiple sclerosis and getting multiple sclerosis after the age of 55 and 65. So, and yes, more observational data would answer this question, hopefully.
Part of the debate, I think, is also nowadays whether in certain patients, in aging population, whether do we have to maintain immunosuppression long, or whether we need to, for example, stop immunosuppression in the aging population. We have learned with COVID that definitely our immune system does not behave the same when we get old, and this makes that our immune system is reacting less in autoimmune diseases, but on the contrary is can have more infections, for example. No? So this is an important piece of information that was not on the table. And also with ECTRIMS and with the National MS Society organized this year a very interesting debate on when, how, to which patients do we need to stop the treatment. And of course, this is not something that we can say for everybody, because it depends on the drug, it depends on the patient, it depends on many comorbidities, etc., etc. But this is part of the conversation who was not here, I would say, very recently. It's really new.
And with that, we are going to hand it over to our audience. That's been a lot of information that's come at you over the past 50 minutes on a range of topics. But this is now your opportunity to ask the panel any questions that you may have on what you've heard. We have people who are going to be roaming around with microphones, so if you keep your hands up, you should get a microphone. We'll start over here.
Yeah, I would like to go all the way back and ask you what kind of treatment seems to be the treatment for the future for MS? Is it going to be these recurring treatments of infusions, or is it going to be like a one-time treatment that's very harsh, like right now when people are getting new marrow? Which way does it seem the research is going?
So the question is, what do we think the future of MS treatments look like? Is it going to be similar to what it is now, or do we think we might have a one-hit therapy?
It's a complex question, but we can say already that the near future is probably not only one treatment for everybody, but it's which sequence of therapeutical proposal we can propose to an individual according to their characteristics. And the key point are to treat early, as soon as possible when it is needed, to adapt to the response, to adapt to the risk, and to adapt to the evolving disease, whether people are aging, whether they are risk-specific, and so on. And on the top of that, probably the future just after would be how we'll add the new possibilities. We have seen today that we may have a drug that influences the disability progression in progressive patients. When are we going to apply this? This is not totally solved, but this will be added to what we have in hand. The crucial question is to have individualized therapeutic approach according to the profiles of patients. We have in hand many solutions already existing. Some are going to be approved probably in the future. And we have to propose the best sequence for optimizing the risk and the benefit for each.
The National MS Society organized a very nice meeting with a very simple aim, which was to cure MS. And I think they said like there are like three important things. No, we have to stop the disease, end the disease, and restore the disease. No, and each one of these three needs probably different approaches. No, for ending the disease, we think that probably the vaccine could be something that could help. For restoring, this is all what we have said about remyelination, no? And then to stop the disease, as Bruno was mentioning, probably there's not one thing for everybody, but yes, we have learned about all the needs to prevent inflammation from the very, very, very beginning, and this is something we know how to do, and maybe we also have now options in terms of even treating this progressive phase that is what is currently more difficult.
Fantastic. I think we have a question. Do we have a microphone that's over here? Yes.
Good day. My name is Susanna. I didn't prepare my question for today, sorry, so it's not very organized. Danish is my mother's tongue, so I'll try in English, but I have a lovely lady here beside of me translating the words I do not remember in English. I am going to be 52 this month. In November 2015, I got the diagnosis of attack-vis sclerosis, you know, with the attacks, yeah. Not the progressive, of course. And for the first 2.5, 3 years, I was undergoing steps of the disease. In my second attack, I could only lie in my bed and breathe. I could chew some food. I couldn't use fork and knife. I couldn't put on my clothes. I couldn't go to toilet. I couldn't do anything. My husband, he did everything physical actually for me. And my children helped me. And I have the most wonderful doctor in, neurologist, thank you. And the first time I met him, he said that it was a CIS. I had to have another attack to be able to conclude sclerosis. And in January 2016, I went to a skiing holiday for 4 days, and I went on ski for the first time in my life. Very fun. And I thought, well, I haven't got sclerosis. It's just... But in March 2016, I started being aching in my back, and it got worse. And that attack was the attack when I couldn't do anything. And I got a rollator to walk around in my house. Well, long story short, in 2017, I think, my physiotherapist, he asked me to walk down to the, you know, when you run on a løbebånd. Thank you. And I couldn't walk without my rollator, and I told him, well, are you crazy? I'm gonna get killed on this machine. And he said, well, just stand up and hold tight, and I'll be here and catch you if you run down. So he started it with 2 kilometers an hour, and I held with both my hands. My right side was not as strong as the left side, and he stood beside me. And I walked 5 minutes, 2 kilometers an hour, and that was a victory for me. And since that day, he helped me training. I used okklusionstraining. Hvad er det? Training when you stop. Sorry, I don't remember. Actually, today I walk. I've been walking for quite a lot of years now. I ride my horses. I train. I don't have fatigue anymore. Actually, I have got my life back. And I think it's very wonderful to listen to all of you and to see all of you here. That brings me some hope. And I just want to tell all of you, we have to work together, all of us, and we have to dare to talk to each other. I'm so frightened. I think I'm going to faint in a while because I'm very scared. But I have to, and you have to. And I don't know what the cure is going to be for any of you. I know what's working for me. And in this month or next month, I'm going to ask my neurologist to take me out of medicine care, because I can heal myself. I have healed myself. I have stopped the development. And he told me last year, if I keep on going, doing what I've done, I can be lucky and my sclerosis can burn out. So that's what I'm aiming for. Yeah. So, yeah, that's just a story.
Thank you very much for sharing your story. And I think there's an important, thank you. I think there's probably an important message out of this that comes back to what we were talking about in terms of lifestyle modifications, and you shared it really nicely in your story about people can find a way to incorporate exercise, incorporate these different lifestyles when it might seem hard. There are ways that, and neurologists can help in this process. Just a really quick comment in the interest of time, because I want to get, how important is that for people to be able to find the way that works for them, just as they have found the way that works for them?
In our center, one of the most popular things is the Nordic walking, which has also patients when they come in our center. We are in a place where there's around a bit of green space, and going there and with friends and walking is, I think, one of the most popular rehabilitation strategies that I definitely know. Yes.
And I think it's very important that people feel that they can do something themselves and they are not dependent solely on the treatment. So somehow they take that you take responsibility for your disease and do the best you can do. And then we can work together.
So in the interest of time, we probably have time for one more quick question, but I will encourage you, we do have a 10-minute break after this. We also do have our 30-minute networking at the end. Definitely come up to everyone who's around and continue to ask your questions during that. Come down here.
Pardon my voice. I've lost it over speaking the past couple of days. Sorry, pardon my voice. My question is we've talked about prevention with lifestyle and diet modification. We've also talked about rehabilitation for cognitive issues. Do we currently have any studies or recommendations for cognitive prevention? And is there something that might contribute? Because there are those of us that have physical limitations, such as the ability to walk, which we know is beneficial. Also, these diets, people that have limitations, whether it be diet or exercise, do you think that it is possible or something that anybody is working on to create a cognitive prevention program as opposed to just rehabilitative?
I would say our brain is like the rest of our body. We have to train. No, that's for sure. We have to train our brain. And that means learning new things every day and being confronted to do cognitive exercise, which means also to be a bit in an uncomfortable way, also to challenge our brain, okay? Because it's like exercise. If you only do what you feel comfortable, you're not doing probably as much, no? And if you want to create this reserve that when you are aging is so helpful, we have to be exercisely trained and cognitively trained.
And there, go ahead, Nancy.
I mean, yeah, so I agree. Keeping the mind active, right? So just like we were talking about exercise, learning a new hobby. For some people, learning a language is a good challenge. Reading, so, you know, not being, let's say, a couch potato and watching television all day, but doing those things, reading, engaging in conversation, using your language, all of those things can help to keep your mind more cognitively sharp and are things that people can proactively do rather than, you know, just waiting until we see a decline and then doing rehabilitation.
And there are research efforts also developing cognitive interventions as treatments that could be prescribed. And that is also part of what the community is working on. So discussed at this meeting, but at other meetings, really consistent efforts. And again, that's imagining other activities as medicine. And there is work in that area.
As you can see, we have a lot that we can talk about. We're going to need to finish here, unfortunately, for a 10-minute break in the interest of time. As I said, I do encourage you to come and talk to everyone. We will be back in 10 minutes with session 2 for a new range of topics with a completely new panel. But before I let everyone here go, can you please thank our amazing panel from session 1 for all of their insights. Am I live? Yes. All right, if I can encourage everyone to back to their tables, we will get started with session 2 in the next couple of minutes. So for session 2, we're going to be delving into a number of new topics, ranging from the new diagnostic criteria in multiple sclerosis, to paediatric MS, to MS nursing, and then we're going to finish session 2 with a focus on NMOSD and MOGAD, which, as we know from this conference, are now a really important part of ECTRIMS, with this year seeing our first ever pre-day held on the Tuesday with a focus on those conditions. With us on panel 2, which we will have appear on the slides in a second, joined by a number of new people. We have Bruno again, who is joining us, who you all remember from session 1. Samara is joining us as well. Romain, Kumaran, KJ, Finn, who you remember from the opening, and Kira. So they represent a range of different areas who will be covering across these topics. As you can see here. Sorry, that was under my control. I'm waiting for the slide to come up, and that was my fault. You can see our people here. So we're going to start this session by talking about the new diagnostic criteria. This was a key topic across ECTRIMS 2024. And so as we continue to advance in both knowledge and technology, revisions to our diagnostic criteria, known as the McDonald Criteria, are really important to ensure that they remain accurate and appropriate. These criteria are what allow clinicians to diagnose MS earlier, and we know that that's really important to enable early management of the disease. And so, as well as that, ensuring that we have these criteria, as we're going to be talking about in these sessions, is really important to make sure that we can accurately diagnose MS as compared to some of these other similar disorders. So with it being a big topic at the conference, we thought we would discuss it in the session, and Finn, I thought I'd throw to you to start this conversation.
Yeah, I think a very good introduction to why diagnostic criteria are important is the story we heard from the person living with MS just 15 minutes ago, who told that the condition was first diagnosed as a clinically isolated syndrome, but it was not possible to say it was MS. That was before we had the previous set of diagnostic criteria from 2017. I wouldn't be surprised that if after 2017 that person would have been diagnosed with MS. And certainly with the new criteria which have been presented at the meeting here in Copenhagen, it becomes a more precise diagnosis. It becomes an earlier diagnosis. There are several technical aspects of the new criteria, which means that we can with much more certainty say that in an older person, possibly presenting with MS, having some MRI lesions in the brain, well, these are likely to be either non-specific or very characteristic of MS, which is really helpful when diagnosing MS in older people being people even younger than me. As soon as you're over 50, you begin to accumulate some MRI lesions. So that's one aspect of it, a more precise diagnosis in slightly older people. Another very important aspect, which I really enjoyed, is that the very early diagnosis, even in people who just have MRI changes on an MRI, brain changes on an MRI, can now be diagnosed with MS. MS is changing from being a diagnosis which requires clinical symptoms to a diagnosis based on biological changes in the brain and spinal cord. And that's really an improvement because up until now, some people have been told, well, we have something on the scan which could become MS. It's not MS at present, but the minute you have symptoms, then it's MS. And obviously that's not logical. So going to a biological framework for diagnosing and classifying MS, it may sound boring, but it's really a breakthrough.
Yeah. Bruno, I don't know if you want to share some thoughts on this as well.
Yeah, thank you. I think Finn has well summarized this new thing. The perception I have to this is that those new criteria, we had already previous criteria, so we can see those new criteria as a kind of toolkit, you know, that can be applied to each specific condition that could be more broadly applied to everybody instead of very narrow population, let's say. So we make no distinction between progressive MS and relapsing MS. We can apply the criteria to the very early stage of the disease, what we were naming radiologically isolated syndrome, which is a kind of biological MS. You have all the signs of MS, but it is not already clinical. And we can, as Finn was saying, also apply to older patients. And this toolkit allows you to have more specificity. What we want is to allow an easy diagnosis, an early diagnosis, but to avoid a false diagnosis. You know, saying you have MS instead of another diagnosis when you do not have MS. And so this is why we have renewed the criteria, we have adapted them. We'll not enter into the details, but the idea behind is that this is a kind of general toolkit, and it might be broadly applied, and not only at different ages maybe, but also in different areas in the world. So of course there will still be work to challenge those criteria, but the general view is that what we wanted to achieve was that, to have a toolkit for everyone.
And so a question that we've received from our online audience is specifically around optic neuritis and whether optic neuritis will be included as part of the new criteria.
Yes, so when we diagnose MS, we look for evidence of affection of areas which are characteristic of MS. And up until now, it's been 3 different types of lesions in the brain, and it's been spinal cord lesions. And over the years, there's been a lot of discussion about including the optic nerve, because we know that 20% of all patients with MS have an optic neuritis as their first symptom. But until now, that has been included as a relapse, but not as one of the characteristic areas. It's now there. It's the 5th region characteristic of MS. But it also means that we have to be more careful in diagnosing MS, because an optic nerve lesion is not specific to MS. We'll hear more about the 2 other MS-like conditions, NMO and MOGAD later. There you can also have optic nerve affection. So if you are uncritical in applying the criteria, then you might arrive at an erroneous diagnosis of MS, just if you look at the optic nerve lesions. So it's very important to take in the other aspects of the diagnostic criteria in order to not arrive at a wrong conclusion.
Perfect. And so, moving on to our next topic, which is paediatric MS. We know that studies that have been done in this area suggest that around 30,000 children and teenagers around the world are living with MS under the age of 18, though everyone tends to agree that this is likely an underestimate from what the real numbers are. Unfortunately, the number of approved treatments for paediatric MS is really limited. And as we know that having been diagnosed at a much younger age, these individuals are living with the disease for an extended period. Effective management of their disease early is critical. And so for that reason, this has again been a really large topic at this year's ECTRIMS. Kumar, and I wonder if I could start with you in terms of providing some updates in terms of where we are with our understanding of paediatric MS and what was discussed at the conference.
Well, there are many things that have been discussed during this meeting. The first important thing to notice is that pediatric MS is a rare disease, in contrast to what the adult are seeing, actually. So the new criteria that have been appeared needs to be validated also in the pediatric world, because as Bruno said, we try to make the diagnosis in the maximum of people earlier, but when the disease is rare, we need to select the specific patients. That means that we call it specificity, and that needs to be looked for, because of course, as my colleague said, it's not because you have an optic neuritis it's going to be an MS. In children, there are many other diagnoses, not only MOGAD, not only NMOSD, you have many other metabolic disease. So this criteria is very important, this new criteria, so we need to validate in children, even though it's already validated a bit. And then we have treatment aspects that has been discussed a lot. Of course, once we talked about children, it is everyone is afraid when we talk about treatment in children, specifically with novel treatments. This is also very important because we fought for a long time asking for studies to be performed. But it's not because we are asking for studies to be performed in order to have approved treatment, that there need to be, and again, another clinical trial that needs to be to replicate the adult trial, so we are losing time again. So now we are thinking about doing trials that may be inclusive with children in order to not to wait along. And there are also markers that we are trying to find out, and in pediatric MS in order to say, we also want to have earlier diagnosis in order to try to put the treatment earlier also. So this is also something very important for us in children. So we are also doing those kind of studies that are ongoing during this meeting.
Yeah. Anyone else want to jump in on pediatric MS? I mean, one of the things, following on from what you were saying, Kumaran, that was discussed a lot at the conference around treatments, is that our understanding now in terms of pediatric MS and adult onset MS is that they are very similar. And so if we have shown efficacy, if we have shown that treatments work in adults with MS, that maybe we don't need to repeat those trials in children, and instead we just need to focus on, are they safe for children? Do you have thoughts, Bruno? I know we've talked about it before as well. Anyone have thoughts on that topic?
I think this echoes what has been discussed in the previous session a little bit. We need new ways of applying treatment, approving treatments in specific populations. And in some time, it's not useful to reproduce a whole program, you know. You have said MS in children is probably the same mechanism, the same biology. So what we need, of course, a few data. We need data about safety because they are smaller, they have different reaction with treatment and so on. So we need data about the safety, probably the pharmacokinetic, so it's different. But redoing a full program to demonstrate in the same biology that the treatment has the same effect, probably is not useful, and we lose time. And for children with MS, it's a problem, it's a pitfall.
It's absolutely right. And this is the other thing is that the children the recovery in children after an attack is really good, motor-wise. Clinically, the children, there are very rare patients in our cohort that needs wheelchair, for example. So this is really important. And the main thing where the children are going to be affected is the cognitive aspects. And again, as they are in school, they are going to be stimulated regularly, but we saw that this cognitive aspect is quite complicated to maintain. Another important thing is because, as you say, of course, I completely agree that we don't need to replicate these kind of studies. And again, the youngest child that we had with the diagnosis of MS is 2 years old. So what do we do? Because all clinical trials that have been done were more than 10 years old. But what we do for the youngsters, again, the pediatric MS is a rare disease, and it's even rarer under 10 years old. So we need to be inclusive for those children too. And the clinical presentation is a bit different in children who are younger too. So of course, these are some specificities for children, and they of course need treatments. And of course, we need to go further because as I said, the mechanism of recovery, remyelination are quite different.
And so following on from that, and I think it's a really important question that's been submitted online, a difficult question to answer. But summarizing what's been said, the question was, what advice and hope can we give to children living with pediatric MS? Commenting that it's awful to be given a diagnosis at such a young age.
So there are two times that I see children when we do the announcement of the diagnosis. The first one is during the hospitalization. Patients come, the child comes for an attack, and you will stay in the hospital. Then we go and do the announcement. This is I think, the easiest way for me, because as you know that when we go and see, we have two parents that are going to be with the child. So when we enter in the room, the child or the adolescent is not going to be the person who's going to talk to us. The first people who are going to talk are parents. You are going to come and ask her what's happening, what's the diagnosis, and et cetera, et cetera, et cetera. So this is the first thing. And when we see them, when I see them in the consultation room, we have three chairs. So we have the table and 3 chairs. The first 2 chairs in front of me are going to be the parents who are going to sit. The child is going to be going to sit behind the parents. And question will come from the parents again. So whenever I see the child, I'll ask, the first question is I will ask to the child in order to understand how he's feeling with the diagnosis. And can you guess what would be his answer when I say, how do you feel? It's going to be, I'm well. I don't know what's happening here. I'm fine. I don't know what I'm doing here. And the person who are going to cry and ask many questions are going to be the parents. So whenever I talk, so this is very important for the child because we need to include them during the diagnosis process and the announcement. So that's why it is easier for me during the hospitalization because I will answer the question to the parents, and then we'll go and discuss with the child. Of course, when the announcement, as in adults, when the announcement is made, everyone will be shocked, and they are not going to be ready to, maybe they will listen, but they may not have included the diagnosis and the announcement. The main work is going to be done by the nurses, actually. Then, because I will do the scientific thing and other stuff, but again, the question will come, and that's why for me the hospitalization is very easy, because nurses are going to come back to the diagnosis and other stuff and what's going to happen, the treatment, and I would have given many treatment, many clinical trials and other stuff, but the information is not going to be. I will use my French first, followed by the parents. During the consultation room, it's going to be different because I will give our consultation is going to be 1 hour because we need to talk to the parents and then to the child, and even after 1 hour, even 2 hours, the information won't be good. So we have another clinical nurse will call them 1 week after and ask them to be if they understood well or not the diagnosis and what would be the follow-up that we can give. So for today, I think, again, the fact that the parents and the child have someone around them who's going to be affected by the disease, and they would have the images of those relatives, and then they would be very afraid. And the child, in the other way, they would be like, well, I'm well, I should not show my anxiety, my depression, or whatever, in order not to affect the parents. So that's why they are going to create some kind of barrier to show that I'm fine, everything's all right. So we have 40% of, around 40% in our cohort, it's similar to the Germans one, 40% of children or adolescents who have anxious depression symptoms. So that's why it's important to tell them, one, that disease is not something very that they can imagine as being very severe. The second thing we have already discussed during the first session, the activities, whatever kind of activities they need to do, some kind of activities to be, of course, mentally be ready to fight against the diagnosis. And then the treatment access. This is something which was really a revolution thing for the kids. Now they have the access for many treatments, not as much as in adults, but still we went from 1 treatment to at least 3 treatments today, which is really important. And again, it's not only injectables. We have oral treatment now, 6 months, every 6 months, and others. So this is the main thing that the parents should know and the children should know.
That was an amazing answer, and I think highlights, again, one of the reasons that we're here, because communication, shared decision-making, making sure information is getting through to the right people was the essence of the answer. And you also perfectly led me into our next topic, so thank you for doing that, which is on MS nursing. Already talked about the role they may play in paediatric MS, so feel free, Kira and KJ, to start with that when we get to you. But we know from data around that MS nurses are playing a really important role in the lives of people living with MS. And people living with MS that have access to MS nurses have better outcomes. The role of the MS nurse is a complicated one, continues to evolve, but they really do act as a primary point of contact for people living with MS. One of the problems around this is that access to specialist nurses does vary around the world, and so it's why it's become a really important part of the ECTRIMS conference that we have gone from probably no sessions a few years ago to a session a couple of years ago to this year having 2 sessions where everyone can get together and discuss some of these issues. Kira, KJ, excited to hear updates from what was discussed at the meeting, but really talking about the role that MS nurses play.
Well, thank you for having us, and it's great. I think it's great having nurses at the table, and we do. Thank you for appreciating the input that we do often have. But I come from Australia, still a little bit jet lagged, so please bear with me. But we had a report done looking at MS nurses in Australia a couple of years ago, and looked at access for people even in our own environment, and just under 50% of our population of about 1,500 people who participated in the study reported having access to an MS nurse, and just over 50% didn't, and that's either because they didn't know we existed or had not been referred to them. We thought initially that might have been a city versus country for the Australian geography. We have big cities around the coast, and the further you move into the centre of the country, the centres become, the populations become much more isolated and remote. But in actual fact, there was as much disparity between access to MS nurses in the cities, with about 1/3 of patients not having access in our cities, as very similar to our regional centres, which was quite surprising. But also in that study, it did also show that the people who did have access to MS nurses did have better outcomes, and so better outcomes in many different areas of their health in relation to adherence to medication, in relation to anxiety, depression, and some of the things that we discussed today. We were very fortunate to have 2 sessions here at ECTRIMS this year, and one was about self-advocacy, and part of our nursing role is to build these relationships with your good selves and people like you, and to help you go through what this is a very complex, long-term chronic medical condition with many facets to it, and it's a very difficult process to go through, and many aspects to it. And we were talking before about paediatrics, and they have their own special needs and specific processes. Also with the older population, there is also that as well, so, and the different types. So it's a very bespoke or very tailored process that we go through in supporting people living with MS. And we're very fortunate this year also to have a really diverse group of nurses that came from all over the world. So we had American, New Zealand, from the UK, someone from Chile who was also a nurse, but also someone living with an MS diagnosis. And it was quite, you know, it is a room full of nurses, and so we think we add value to people living with MS, and there is research that indicates that. And so we were sharing ideas around brain health, and it was something that we've done a lot of sessions outside the nursing sessions as well, and the brain health is a very strong message that was right throughout the conference, I think, this year. And I know that in my practice, I suppose I haven't necessarily called it brain health because I've been around for a long time, and before the Brain Health Time Matters report. But I often talk about disease-modifying behaviours, and so there's a lot of focus initially on disease-modifying treatments, but these disease-modifying behaviours that we've all been talking about, and in the first session, are so vitally important and really to the mental health, and also learning how to self-advocate and how important that is for everybody, to have the confidence to know what your goals are, and everyone's goals are going to be different and how they're achieved is going to be different. But MS nurses are well placed if you're fortunate enough to have access to them that can help you navigate that. What does that look like? Who do I tap into? And you build relationships with your MS nurses that tend to be long lasting. In the Australian research project, they actually showed that patients that had access to MS nurses, the longer the relationship they had with their MS nurses, the more satisfied they were with that relationship. So often that's around trust, but also getting to know. We listen, we go on that journey with you a little bit. I don't love that word, the journey, but that's what I often say. But you know, we go through that together, and I love seeing my patients and just being able to say, hi, how's it going? Not much, excellent, how's the new grandchild? And just building those relationships and living well with MS. I try very hard, and I think Kira would be the same, that, you know, a lot of the emphasis of what we do in building relationships and giving you those strategies around, you know, self-advocacy and self-efficacy is just to have the tools, and you can use them in the way that you need to get the most out of your life, and through with brain health and all of those things, so you can live your best life and live really well with MS. And so it was a little bit reflected. We also had a nurse, I forgot to mention before, from the UAE. So that was amazing too, because her role, she feels, is quite in its infancy. She's been working as a nurse, but she is kicking a lot of goals, and made me question a little bit what I've been doing with my life as an MS nurse. And so it was a great opportunity to get together and see that we actually, despite the differences and differences around access around the globe, that we actually have a lot in common. And I think with everyone on this panel, I think our main aim is you guys. You are the centre of everything that we're discussing. You are the centre of everything we're trying to do. And whether that is around therapies and these other, you know, brain health strategies, I think it was very clear with the nursing sessions in particular that we want to band together, communicate together, and work collaboratively, so there is more even distribution of access for everybody globally living with MS.
Yeah. And I think onto that, Brett, as well, and KJ has hit on a lot of it, the 2 sessions really hit home about the importance of the role of the MS nurse and what they bring. And I think it's really important as well that we figure out and define what that role is, because it's so important, and it's been alluded to here in the panel, the importance of having that connection and having that MS nurse. And it can be difficult when things are so different across the world. And I suppose it's been great to network with KJ and a lot of the nurses from Australia specifically, because they've done that report looking at what is the role of the MS nurse, what's the benefit for patients, the patient-reported outcomes that come from having that relationship with an MS nurse. And from an Irish perspective, we want to strive now to do a similar report, because we don't have anything like that. Unfortunately, where I'm from an Irish side, a lot of our MS nurses have other roles. So they're not just specifically there as a contact point for patients living with MS, but they're also there for other neurological conditions. Services are stretched, and it comes down then to resources and money and time. But we need to, again, reiterate the important role that the nurse plays. And I come to this, I suppose, with a very unique perspective. I come as a nurse and a researcher who also lives with MS. So I suppose I'm biased on two sides. From the professional perspective, I know how important the role of the nurse is, and the importance of having a relationship and the trust that forms there. I trust my MS nurse a lot more than I do my neurologist, because I meet them on a regular basis. I can confide in them, I can discuss with them. And straight away, even without having that data, that narrative says the MS nurses are vital. They need to be there, and they need to be there to support the MS community. And I think the next step is, yes, that gathering of data and having those reports to say, yes, we are important and we need more MS nurses. In Ireland, we're way below the European Union recommendation for neurologists and neurology specialist nurses. And the next stage then is that advocacy portion. And I think it's advocacy from neurologists to say we need more MS nurses and the important role they bring, and the advocacy from the individual patients themselves to say we need more support and we need more nurses, because the role is vital.
And I think I think it's fair to say, if you aren't fortunate enough to have access to an MS nurse, you should maybe have that discussion with your MS medical specialist, your neurologist who manages your MS, to ask, is there someone there that you can tap into in that way for education, for follow-up, for continuity, for answering those questions. Time is of the essence for a lot of us in healthcare, and doctors very much so, and depending on where you live in the world, as Kira was saying, the access isn't the same for everybody, but we're all trying with the same intent.
We've had a number of questions submitted around people commenting on their own experiences with having an MS nurse and how beneficial they've found, and wondering if there is any data on it. I think you have already answered that question through what you've said. So in the interest of time, we are going to move on so that we have plenty of time for our audience questions at the end. And so the last topic that we're going to discuss in session 2 is now shifting to discuss NMOSD and MOGAD. So as a little bit of background on this, like MS, NMOSD and MOGAD are autoimmune diseases that cause damage to myelin. However, while similarities exist with MS, these diseases all have their own unique aspects that need to be properly understood. We know that accurate diagnosis, as we already talked about at the very start of this session, and treatment are really important for managing these conditions effectively. And as I already mentioned, at ECTRIMS 2024, we had for the first time a pre-day on the Tuesday where the conference was initiated with a discussion solely focused on these conditions, as well as paediatric MS and some other rare neurological conditions. And so for this to get started, I think considering the enhanced focus that we've had on these conditions, Samira, I wouldn't mind starting with you on this and get your opinion again around how important it is for you that you see this sort of focus on these conditions being placed at such a big meeting.
Hello, can you guys hear me? Okay, hi. Hi everyone, my name is Samira. I am going to go off script for just 1 second because of curiosity looking at this full room. Raise your hand or make some noise or enter into the chat if you have MS. Yes, cool. Okay, raise your hand, make some noise or enter in the chat if you have NMOSD. Yay! And what about MOGAD? How much MOGAD do we have in here? Okay, cool, awesome, welcome. All right, so to answer your question, Brett, I'll just say 10 years ago when I was diagnosed with seronegative NMO, no one was really talking about it. And you know, everything that you saw on the internet, as we know, was pretty devastating. It was almost like a death sentence was given to us at diagnosis. So 10 years later, to be at the largest MS conference in the world and to have not only a day dedicated scientifically to NMOSD and MOGAD, but also to include our diseases in what is, I believe, the largest patient day and coming together of MS, NMOSD, and MOGAD patients is absolutely inspiring, and I think it provides a lot of hope, not just for the patients and the caregivers, but of course the researchers who are incredibly invested in our diseases. So I'd love to thank ECTRIMS and Congrex for amplifying our diseases on such a platform, because it's so important to our well-being as patients, to the clinicians and researchers who spend so much time working on these diseases, and even our therapy partners who are making highly efficacious treatments for us. I have one more poll for the audience, actually. Raise your hand, make some noise, or enter into the chat if this is your very first patient day. Wow, that's special. I remember, yeah, for you too, cool. I remember the first time I ever met a patient in real life. It was about 8-9 years ago. And it totally changed the trajectory of how I dealt with my disease and my diagnostic journey. It can really be such a turning point in our lives, not just as patients, but of course for our families as well, because as we all know, living with these diseases doesn't just affect us, it affects our families and those around us and those who love us as well. So just a very warm welcome, and thank you for taking the time on a Friday afternoon to be here. And thank you, ECTRIMS and Congrex, and all these wonderful panelists up here with me. Mar and Bruno, for your vision and helping us bring this to life. It's such an honor for me to be here.
Thank you. And Roman, I might throw to you to discuss what you thought some of the highlights were of what has been a large focus on these conditions throughout the meeting.
First of all, of course, I am also very impressed with the number of attendees for such an event. For us, it's very important to share your knowledge or experience, and the other way around, your knowledge or experience. So, going back to your question, I think it was a very unique ECTRIMS meeting with this pre-day dedicated to this rare disorder. For us, working on this rare disorder, Kumaran on pediatric onset multiple sclerosis, Sumara and I working on this NMOSD and MOGAD that are very rare disorder. It's something very important, just putting some spotlights under these rare disorders, very important for us, very important for the patient, very important also for the scientific committee. And we also have the opportunity to share our knowledge with also other rare disorders that are a lot of similarities with NMOSD and MOGAD. So first of all, this is for us very unique and important. Then after, as Sumaya said, during the classical meeting, we are also dealing with NMOSD and MOGAD. And as Bruno said, there are some similarities between those conditions, but there are major differences, mainly regarding the clinical course, the risk of disability, and the treatment. This is very important. Unfortunately, the treatment that we are using in MS are not so efficient, and sometimes that are harmful for patients suffering from NMOSD and MOGAD. It is why it's very important to have a robust clinical diagnosis to make the difference at the start of the condition to prevent to be harmful to the patient. So the new diagnosis criteria for MS are important as well to decipher in between those conditions. So they are a bit complicated, to my opinion, but they are complicated because it is necessary, because it's sometimes very challenging to make a difference in between NMOSD, MOGAD, and MS. So we need to rely on a toolkit that is using not only the clinical symptoms that are quite similar in between those conditions, but we will need to use more performant device like MRI, like biomarkers. So this is also was for me something a milestone of this meeting. Regarding NMOSD, we also are facing a new era because we have access now to new drugs, very specific drugs for this condition, that are unfortunately very expensive, so not accessible to any of the countries in the world, mainly accessible in Western countries. And unfortunately as well, those conditions, and especially NMOSD, are affecting mainly patients from Africa, from Middle East, from Latin America, for whose access to those treatments is very limited. So we are also to work on inclusivity, work on how they can have access to those drugs, and evaluating all drugs that are less expensive but possibly also efficient. So I discussed about biomarkers because we are lacking still now marker of response to treatment. So it's something very important, especially for MOGAD. MOGAD is a bit different from MS and NMOSD because it's a condition that is not active all along the period of life of the patient. MOGAD is very active at the start of the disease, the 2 first years, 3 first years, but naturally, without any treatment, it will become less and less active. So for those patients, we have to identify who will be the patient for whose I will need to treat and go on treating, and who are the patients that I can stop the treatment. But also, I think we have discussed during the session about what is called de-escalation in MS patients, because the treatment that we are provided in MS patients are very efficient, as you know, but that can be deleterious, especially with the risk of infection. And we have to question ourselves and discuss with you what is the balance in between the benefit of the treatment, but also the risk of the treatment and the need of the treatment. Should we need to treat all along the life MS patient? I think the question is open. For MOGAD, it's clearly no. We have a moment that we can stop treatment. For NMOSD, it's again a bit different. Unfortunately, NMOSD is a condition that is active all along the life of a patient. We have patients starting NMOSD at the early age. There are few patients, but there are pediatric patients. And we have patients that started the NMOSD at the age of 70, 80. So it's totally different from MS. And when you are starting NMOSD, even very earlier, the condition will be active all along the life. So for NMOSD, there is no room for de-escalation or stopping treatment. So it's also something that, it's a concept that, to my knowledge, it's quite new in the world of MS, but very important. And last but not the least, regarding biomarkers, I told you that we are working on biomarker for response to treatment, but something also for me very important is to decipher in between what we are calling a relapse, activity, clinical activity of the disorder versus pseudo-relapse, that are symptoms that are not really related to the activity of the disease, but possibly other things like fatigue, infection. And sometimes for you, patient, for us, clinicians, it's very difficult to make the difference in between a relapse and a pseudo-relapse. And the conclusion is very different. If it's a relapse, we have to conclude that the treatment that is proposed is not efficient, and we have to change the treatment, so it has a huge impact. And if it's a pseudo-relapse, we should not change the treatment. So it's very important to have tools to decipher in between. And recently, we demonstrated that the current use of the tools that we have are not so efficient. In the near future, we will probably use another tool, which is a biomarker, a blood sampling, that can show us that it is a relapse versus it is not a relapse. It's not yet used in routine, but there are some preliminary data that are quite convincing, and it will be in association, of course, with the symptoms, association with the clinical evaluation, association to the MRI, but the whole picture will be very helpful for us to decipher versus relapse and pseudo-relapse. So I think it was also something very important for us.
Roman, just in the spirit of inclusivity, I do think we need to address seronegative patients because there are so many in the world, myself included. So can you just talk about seronegative patients? What does the future look like for us and sort of the research behind that?
So it's not a nice word, seronegative patient, to my opinion. It's also, we can use the term double negative is not so good neither. So it's an unknown mechanism associated to the condition, and it's more obvious that it's unknown and not only seronegative. You are not defined by something negative, you are defined by something that's still unknown. We have to work on that. So as you probably know, for the next year, we are working on new criteria for those rare disorders. And one of the major goals of those new criteria would be to more clearly define who are these patients that are not fulfilling the classical criteria for antibody-mediated disorder like NMOSD and MOGAD. The goal of that, it would be to help to better characterize the condition, to help to support research for this condition, and at the end, eventually, to propose new treatment. So I think we are facing a new era for that, and I hope it will be successful, but as you said, it's still a clear unmet need in the field.
My turn to ask you also the questions, because the MOGAD, particularly NMOSD in children, is really, really rare. That's what we saw. And MOGAD, for example, is also something we thought as a pediatric neurologist that it's a frequent disease in children. So do you think that research in children may help to understand the mechanism? And do you think that the fact that the disease evolution would help you go further for the biomarkers and the other stuff?
So you're right. As we discussed, MS for children is rare in comparison to MS in adults. NMOSD for children are very rare in comparison for NMOSD in adults, but MOGAD is the other way around. It's even more frequent in the pediatric population than adult population, so we have a lot to learn from you, from your patient, because MOGAD is a very specific condition, as I said. It's quite different in terms of natural history. It's also quite different in terms of mechanism. And something very specific, there are patients that will experience only one episode. And these patients should not be treated, of course, should not be treated by an immunotherapy that have huge impact of the immune system, especially an immune system in a child that is something that is in development. So we have to rely on your work, on our research to identify those patients that will never need a treatment and apply it in the cohort of patients with an adult start. Maya, maybe you want to add something.
I have a question for the both of you, actually, while I have you here. You know, for our live audience and the virtual audience, NMOSD and MOGAD has evolved so much at such a rapid pace, as you both know and have experienced in research and breakthroughs in medicine and identifying biomarkers, making them commercially available, and et cetera, et cetera. And I think that the next 10 years will also be just as exciting, and we'll see so much happen in our field. But my question to you, if you could just answer to the audience watching, what is it that we as patients can do and contribute to advance it even further and maybe accelerate the pace of all of this?
I will start because children are priority, right?
Of course.
I don't know whether in the audience are there parents with children with MOGAD, or can you raise your hand? So you can see that it's very quite rare, but still it is quite frequent in our practice actually when we deal with demyelinating diseases, autoimmune demyelinating diseases. So I think these kind of meetings are very important for me and for us globally, because we talk, the first thing that we need to know is the child. And again, when you look for MOGAD in children or even NMOSD, the mean age is quite low. So we need to understand what the children are living in order to understand what they really need, actually. That's one point. And then what the parents are living and what they see to their case. Of course, when we see the patient, maybe it's going to be 30 minutes to 1 hour, but the parents are living with them, so we need to know what their main needs are. So this is really important for us, and then of course, you're going to help us in those particular aspects, actually.
So I will maybe provide an example of why your experience, your feeling are important for us. There has been, as I told you, new treatment for NMOSD, and one of these treatments is very efficient. And for the trial, so the evaluation of the treatment, there were 3 ways of evaluating what is the clinical activity, what is a relapse. The first was patient-reported relapse. So the patient is saying, I have a relapse. Then after, it was evaluated by what we call the treating physician, your neurologist. And at the third step was an evaluation that we call an expert commission. And very surprisingly, there were 13 patients that reported some symptoms. At the end, it was not considered neither by the treating physician nor by the expert as a relapse. But when using these very powerful tools that I was discussing just before, these biomarkers, the patient was right. So we have to listen to you because you know you are the one that is knowing the best what is happening to your body, what is happening to your central nervous system, and we have a lot to learn from you. So I think for us it was making us humble. We do not have the best tool to evaluate what is happening to you, and we have to listen to you. Yeah.
Good.
And so on that note, I'm going to put my moderator hat on, and in the interest of time, I do want to listen to our audience and throw it over to you now for some question and answer. We have moved to that part. I think it is very clear why we needed to have an extra day in the calendar for these conditions, because there is a lot to talk about. So for anyone in the audience now, this is your time to ask some questions of anyone on the panel about anything that we've discussed in session 2. We only have time for a couple of quick questions, but there is going to be a networking time after this where you will also be able to ask any questions that you have. Do we have any questions from the audience? One here? Yes. Oh, sorry, over here.
Hi, I have a question about AI. I think Bruno mentioned a student that developed some app, if I remember well, MS Brain, I don't know what you said. Are you using, or can you use AI to crunch all the MS data you have to get information about disease development and progression and predict maybe how the onset of the disease?
So clearly AI can provide very interesting service. This is clear. We have to master it, we have to ask the right question, but we have seen that using algorithms provided by AI, you can combine biological markers and clinical data to improve the characterization or the prediction of a disease. This has been done in MS. There is no reason that it cannot be done in pediatric MS, in MOGAD, or in MOSD. You have so many potential applications. The one I mentioned during the first session was an imaging approach, but you can combine complex biological data together and analyze them by AI, and you can combine any kind of data and try to find algorithms that help you. So it is an accelerator. It's not a solution per se, probably, but it's a great accelerator to have results and to have new data.
Merci.
Do we have any other questions? Time for one more question. Over here. Yep.
Thank you so much. I think maybe you're able to answer this because you are from all over the world of MS research. Given this big importance on early intervention and on the new McDonald Criteria and showing the link between EBV and MS, are there any healthcare systems actually looking into screening high-risk people so that we're able to catch more people before they have symptoms?
So, Finn, yes, please.
Yes, that was in fact a theme in some of the presentations given here. People are beginning to look at high-risk profiles. Bruno mentioned that, for instance, by characterizing EBV strains and adding that on top of genetic information, environmental risk factors, it's probably going to be possible to give a much better risk estimate for individuals at risk of MS, or maybe even for the general population. And with the new McDonald criteria, it would now be possible to make an MS diagnosis in patients identified by screening programs. But there is a lot of work to validate these methods and then consider, will we then take the consequence and say, okay, if you have non-symptomatic or preclinical MS, should we treat? And we don't have the solutions to whom to treat yet. But I would suspect that maybe in as early as 5 years' time or something like that, we will have ways to identify high-risk subjects who can have a screening MRI, for instance. But it's going to cost. That's a completely different aspect of it. Who's going to pay for it?
Perfect. We probably need to hang on for questions, but we will have a networking. We're just going to do a quick closing, and then we will have some networking. So in the interest of time, we will wrap up here. Before I get Finn, you to lead us in some closing remarks, can I get everyone to thank all of our fantastic members from session 2 for sharing their wonderful insights. And Finn, please.
So this has really been a fascinating patient community day. I hope that you have been participating here in the physical audience. You out there online have experienced that this has helped you understand what is being done with MS better and what we are actually struggling to understand and do to improve the life of people living with MS. It's certainly been highly rewarding for me to participate here. It's sort of been a two-way communication, and I really appreciate that. It's been fascinating. And I think this really gives an excellent conclusion to what has, in my opinion, been a highly successful ECTRIMS meeting here in Copenhagen. And the patient community day is really an excellent way of concluding that. So I'd like to thank my fellow panel members for participating. I would like to thank you here physically, the online audience, and not least you, Brett, for excellent facilitation of these discussions today.
Bruno.
So I would hand over to you.
I think that everything has been said. I would also warmly thank the panel, Brett, for helping us on this initiative, and you all present on site or per connection to be involved in this event. Any feedback about it would be greatly appreciated. As I introduced, this is an evolving concept, and we can adapt because we are going on to reproduce this event at the next ECTRIMS and after. So it's becoming a classical, regular meeting together. So do not hesitate to send any of your comments. And overall, ECTRIMS is really proud, glad to organize this for you all, and thank you very much. And this is now the closing. Thank also to the Danish MS Society who helped us. And now the Congress is really ended. This is the second time I closed it. And next year, it will be in the nice city of Barcelona.
Thank you, Bruno. Just some last thanks from me. Thank you again to all of our panel members, both from session 2 and from session 1, for sharing their time. As I said earlier, they were all extremely excited to participate, and their enthusiasm has made my job really easy. As well as that, I want to thank a number of people behind the scenes who you haven't seen participate today, but who without this wouldn't have happened. The Congress team, the marketing and communications team, who have put in countless hours to make this happen. Can we give them a round of applause? Because without that support, we would not be able to do this at all. So thank you to all the people there. Thank you to the Danish MS Society, to all of our supporting partners, again, who without this event would not be possible. It's been a privilege for me to be involved. Thank everyone in the audience, both here in person and online, for making this one of the most amazing events we've had. Certainly a hugely successful patient community day. The last thing that we want to ask of you, as well as networking with us during the next little while, is that the communications team will be set up in the back my right corner here to record some little videos. If you are willing to share your thoughts on your experience today, that would be much appreciated. We really do value your feedback. As Bruno said, we want this to be bigger and better next year in Barcelona. So thank you again, everyone, for participating. It's been great. Thanks very much.